All right, so we're on question number 4. Sorry for that break in transmission. The answer is C, okay? Do we agree with the answer C? We're talking about first line management. You only give your antihypertensive if after your first line non-pharmacological method does not work. Okay, do we understand? See the patient up and loosen tight clothing. Okay, do we understand that?
Yes.
Okay, or you don't agree? You understand, but you don't agree. Okay, so number 5. A 25-year-old male patient with severe TBI is in the OR for decompressive craniotomy. Interpretively, the blood pressure drops to 70/40 millimeters of mercury. Which of the following is the most important immediate anesthetic goal? Quickly, our time is running. A, B, C, D, or E?
B.
C.
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 Which one? B, C, or which one?
C.
C.
C. C.
C.
Is everybody agree C?
I think it's B. Yeah, for me too. I think the answer is B.
Answer is B.
C.
C. The answer is C. C is correct, okay? You want to maintain CPP, so you defend your blood pressure. Okay, during the evacuation of an acute hematoma, the anesthetic notices sudden bradycardia, hypertension, and decreased brain compliance. Which of the following is the most appropriate immediate action? Anyone?
A.
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 A, correct.
A.
Correct. Correct. A is correct.
A.
Okay. All right, these are the short answer questions. This is how it goes. I won't ask you to answer that because of our time, okay? But let's look at number 2. Number 2 looks interesting. A 35-year-old with chronic T4 spinal cord injury undergoes bladder catheterization, suddenly develops severe headache, blood pressure 220/120 millimeters of mercury, bradycardia, sweating above the lesion. Hey, what is your most likely diagnosis? Quickly.
Autonomic dysreflexia.
Autonomic dysreflexia, correct. Number B, list 3 immediate management steps.
Sit the patient up, loosen tight clothing. You can dangle his legs.
Number 1. Number 2,
Remove shade.
sit the patient up, loose, tighten clothes. I'll take. Number 2, there are 3 immediate
If
management.
persistent, if persistent, we can give a short-acting antihypertensive like nitroglycerin.
Yeah, that will answer C. If the BP remains high, you give that. Okay, nitroglycerin on the pain. We're talking about immediate management before your drug. Stop the stimuli, isn't it? All right, bladder catheterization is a stimuli, so you stop it, isn't it? You stop the stimuli. Okay, if the blood pressure remains high, you give your short-acting nitroglycerin, pain, or your vasodilator. Name 2 common triggers of this condition. We have one,
Bladder
bladder catheterization. Which other one?
A full rectum.
Yeah,
Constipation.
bowel impaction, correct. What's the other one? Any other one? Any other one? Bed sores, okay? Pressure sores. These are some of the common triggers of autonomic dysreflexia, all right? So quickly, another question I would like to add here is, if you have a patient with chronic T4 So spinal cord injury patient coming for anesthesia elective procedure, what will be your choice of anesthetic technique and why? Okay, patient is coming for bladder exploration. Chronic T4 spinal cord injury injured patient coming for bladder exploration. What will be your anesthetic technique and why? Anyone?
So if the patient has a history of autonomic dysreflexia, then the patient does need an anesthetic even though the level is above T10. So I would probably go for a spinal, which would abolish that reflex.
Beautiful, beautiful. All right. So spinal anesthesia, all right, below the level of injury helps to prevent autonomic dysreflexia. All right. And a lot of times, we just think that patient does not have sensation below the level of injury, but they are still prone to autonomic dysreflexia. So I always like to give, sometimes you can even do a saddle block. Okay. See, if I was right between spinal and saddle block in this patient, and why will saddle block be better than subarachnoid block in this patient?
So I think depending on the level that you can achieve with the saddle block, because the saddle block will usually block the S region and L and lower L region. So S2 to S4, maybe lower lumbar. But then the spinal, you can then go to above the level of the bladder, and the bladder innervation comes from about T10.
Beautiful answer, correct reasoning. I agree with you. All right, I hope we are following the discussion. All right. So let's see if we can. Um, okay, let's leave this one. So let's quickly go. We have 30 minutes more. All right, so spinal and head injuries are leading causes of death and disability worldwide. According to WHO, about 69 million new cases of TBI occur annually, and road traffic accidents account for more than half of these cases. Spinal cord injury has an incidence of about 40 to 80 cases per million population per year. All right, and these injuries occur more commonly among young adults with resultant long-term socioeconomic impact. And as anesthetists, we do play a vital role in managing this group of patients. All right, so head injuries, mechanism of injury could be blunt trauma from road traffic collisions, falls, or sport injuries. It could be penetrating, gunshot wounds, stabbings. All right. Associated, head injury can be as a part of polytrauma case following chest, abdominal, and extremity injuries. All right. You can see the mechanism of head injury in the slide to the right. You have the blunt trauma, acceleration, deceleration, penetrating injury, gunshot or stab wound, or you have blast injury. So pathophysiology of head injury, we have traumatic brain injuries, which could be primary or secondary. All right, this is important because primary injury occurs at the moment of impact and includes skull fractures, contusions, brain lacerations, diffuse incisional injury, intracranial hemorrhages. All right, note that primary brain injury are usually irreversible, and anesthetic or critical care management cannot change the primary injury. Secondary brain injury develops minutes to days later, and they are potentially preventable. Secondary brain injury are caused by the 5H, like I call them, hypoxia, hypotension, hypercapnia, hypo or hyperglycemia, hypertension, or hypothermia. All right, the goal of anesthesia and critical care management is the prevention of these secondary brain insults. So head injuries can be classified based on severity using the Glasgow Coma scale into mild, moderate, and severe. You It can also be classified according to morphology. It can be focal or diffuse injuries. The focal injuries include contusions, intracranial hemorrhages, hematomas. Diffuse injuries include the diffuse external injury and cerebral edema. And it's important for us to know this. Most of the diffuse injuries are not amenable to a neurosurgical intervention. All right. Head injuries may also be classified according to the mechanism: open or penetrating, which can result from stab or gunshot, like we mentioned. This can result in skull fractures with a breach of the dura. All right. Closed or blunt injury from isolation, deceleration, injuries, or rotational forces. All right. Then by timing, primary or secondary injury, like we mentioned before. All right, let's remind ourselves of the Morokelian doctrine or hypothesis, which states that the skull is a rigid structure with a fixed volume comprising of the brain tissue, making up about 80%, the blood volume of 10%, and the cells of 10%. So an increase in any of the components of the skull content must result in compensating decrease in others, all right? And if this does not occur, you have your rise in intracranial pressure. And what does this do? It impairs your cerebral perfusion pressure, which is the diving pressure to ensure brain perfusion, all right? So increase in ICP should be prevented because it impairs your cerebral perfusion pressure. In all our management, our goal is to maintain cerebral perfusion pressure above 60 millimeters of mercury. And you can do this either by defending your MAP or controlling your ICP. So management of head and spinal cord injuries usually should begin from the pre-hospital state or an emergency department. All right, and the principle of initial management is to prevent secondary injury, all right, by ensuring adequate oxygenation and perfusion. As an anesthetist, most of the times we're not involved in the pre-hospital care, but it's important for us to know so that we can also train our paramedics. Okay, always follow ABCD approach with cervical spine protection at all times. A patient with head injury must always be assumed to have cervical spine injury until it's ruled out. Okay, airway protection. Early endotracheal intubation is encouraged, all right, especially for patients with low GCS, all right, patient with airway obstruction, maybe from associated, trauma to the upper airway. Please, colleagues, when you join, mute your mic, okay? Hypoventilation or hypoxia despite supplemental oxygen. All right, because most of them are traumatic, you want to ensure you employ rapid sequence induction, okay, and intubation. Always avoid hyperextension of the neck, okay. Inline cervical spine stabilization must be ensured during all airway maneuvers. Okay, breathing. The B, provide 100% oxygen, all right? And this is to avoid hypoxia, which worsens outcome like I mentioned. Monitor your SpO2 and end-tidal CO2, all right? This is important. Ensure you maintain normal capnia, okay? And PaCO2 between 35 and 40. Hyperventilation only serves as a temporary measure, especially for severe intracranial hypertensive crisis. Okay, C, treat hypotension aggressively. A single episode of hypotension can worsen outcomes. So target your systolic blood pressure above 100 millimeters of mercury. Avoid hypovolemia. Okay, use isotonic crystalloids. Okay, avoid hypotonic solutions such as 5% dextrose or 0.5% saline, as they can worsen cerebral edema. You must be able to recognize neurogenic shock early, especially in patients with high spinal injuries, T6 and above. All right, and this comes with hypotension, with bradycardia. You want to treat with vasopressors because it's a loss of sympathetic tone. D, disability, the rapid GCS assessment, all right, with your eye, verbal, and motor functions. Oh, yes. So a GCS of 8 and below indicates severe brain injury and the need for airway protection. You want to do your pupillary light reflex. Unequal or fixed dilated pupils may be an early indication of intracranial hypertension or herniation syndromes. Always assess motor power and lip movement, especially if there's asymmetry, which may suggest intracranial hematoma or even involvement of the spinal cord. Note that the neurological status must be assessed frequently as this may change. And a sudden drop in GCS is a neurosurgical emergency, all right, with neurosurgical involvement. Exposure. Yes, we need to do this. We need to minimize unnecessary exposure in as much as complete exposure guarantees thorough assessment of all injuries. A lot of times we concentrate on what is obvious and the patient may be bleeding, all right, intra-abdominally. All right, so uncover the patient, but ensure you protect the patient against hypothermia, which can lead to the later triad of coagulopathy, acidosis, and shock. Make sure that the ambient temperature in the emergency operating room is kept high, all right, to prevent hypothermia and deleterious consequences. All right, decided to put this here. I hope we know the later triad. Okay, coagulopathy, acidosis, and shock. And this can give a cascade of a poor outcome. So coagulopathy can lead to uncontrolled bleeding, reduced tissue perfusion due to acidosis with latent accumulation, and shock, persistent bleeding, inadequate perfusion will lead to shock. So it's a cascade, all right, and we call it the later triad. And one of the things that usually precipitate this is hypothermia, and that is why it's important for you to only expose where you are examining, and after that you cover the patient and maintain normal or increased ambient temperature. All right, so pre-hospital, you want to do CHCT for all moderate and severe TBI or patients who have unexplained neurological changes. Okay, should have an emergency CT brain done. You want to do cervical spine imaging or your trauma series of X-rays or MRI, all right, to rule out cervical spine injury. If fast, extended focus assessment sonography of trauma, all right, is important. And I think, every anesthetist and critical care physician should be able to perform an EFAST. It's a bedside exam that helps us rule out any intra-abdominal bleeding. And we've done that. We've saved a lot of patients in our ICU because of EFAST, okay? Anticipate the need for rapid transfer to the OR or ICU as the case may be, all right? The EFAST is actually an expansion of your original FAST, all right? And it has to do with, it incorporated your lung ultrasound and the cardiac ultrasound. But the traditional FAST exams look at the Morrison's patch to look for free fluid between your liver and kidney, the splenorenal recess, free fluid between the spleen and the kidney. And you want to look at the patch of Douglas in females or the retovesical patch in males for free fluid around the bladder. You want to detect pericardiac effusion or tamponade, all right? And this won't take you more than 5 minutes, at most 10 minutes to do in 3 hands. Look at the anterior chest to rule out pneumothorax, and laterally you can look out for periac fluid accumulation. And these are things that are amenable to urgent surgical intervention. So we shouldn't just look at the head and spine alone. We should also try to do EFAS. Okay, so what are the priorities for the anesthetists in the emergency department? Luckily, most of the emergency physicians can secure airway, but sometimes we are called as anesthetists to secure the airway safely. This is important. It's not just securing the airway, you must do it safely and fast. Optimize oxygenation, ventilation, and hemodynamics. And you must also be able to coordinate with the trauma and neurosurgical surgeons for immediate intervention as required. Okay, so the anesthetic consideration, remember caps, okay? I thought about this, put a cap on secondary injury. So how do you mean caps? Put caps, your caps on, or you put a cap on secondary injury. C, control the ICP, all right? Avoid secondary insults. Like we mentioned, preserve your CPP and to provide surgical anesthesia and patient comfort. And this is important right from induction of anesthesia throughout maintenance and even emergence and even in the post anesthesia care unit, all right? So you need to provide surgical anesthesia for the patient. So put on your caps when you see a patient with head or spinal cord injury. So airway management, rapid sequence induction and intubation with manual inline stabilization of the C-spine. All right, your choice of induction agent should be guided, all right, by the hemodynamic status of the patient. Okay, etomidate is hemodynamically stable. Terpenton provides some neuroprotection, and propofol also helps. All right, you must always try to blunt sympathetic response to laryngoscopy and endotracheal intubation. You can do that with your opioid, remifentanil, look anesthetic agent, or your second dose of your induction agent. In all of this, you want to avoid hypoxia during airway maneuvering, hypercapnia. You don't want the patient to cough or balk on you. And these are the things that can lead to intracranial hypertension with poor outcome. All right, so this is manual inline stabilization. You need two people, all right, just shortly before intubation, you want to remove the collar, your cervical collar, and stabilize. See the way the hand is put there, all right? Stabilize the spine and let the most senior person do a rapid laryngoscopic and intubation, all right? This is not a patient you want a trainee or somebody who is learning to secure the airway. So manual inline stabilization with coordination between the two people involved is very important to limit secondary injury to the spinal cord. All right, you want to provide intermittent positive pressure ventilation. We mentioned this before. Avoid prophylactic hypertension. All right, this can lead to cerebral vasoconstriction and worsen your cerebral perfusion pressure. Use your PEEP cautiously. Sometimes we increase PEEP to increase oxygenation, but don't forget that excessive PEEP will reduce venous return due to increase in interthoracic pressure, and all this will increase your ICP and compromise your CPP. Hemodynamic management, aim for CPP of greater than 60. Avoid hypotension, like I mentioned. Do not hesitate to use your vasopressor. I use the word defend your MAP at all times. Avoid large fluid shift, and we prefer isotonic crystalloids, like your 0.9% saline. Choice of anesthetic agent is important. We mentioned this. A lot of times we can use either TIVA, total intravenous anesthesia, or if you want to use gas anesthesia, make sure you use sevoflurane, all right? Even isoflurane can be used, all right, at less than 1% MAC. Always avoid the nitrous oxide because it can expand EFE spaces and increase your ICP. Suzametonium has been acceptable, especially, all right, for rapid muscle relaxation. You can also use your depolarizing muscle agent like your rocuronium. Sometimes those days when we started, we only had pancuronium, all right, which is long acting, but make sure that you're able to secure the airway before you give such long acting, not depolarizing agent. But these days, you guys are lucky you have rocuronium with your sugar madness in most places, so that will be preferred. If you have sugar madness and all that, I will refer it to suzametonium, although the transient rise in ICP is said not to be very significant. It's better to be wise than to be foolish. All right, intraoperatively, you want to ensure that you manage your ICP, keep your ICP less than 20 at all times. And how do you do it? I have this mnemonic head. All right, so head up position helps to facilitate cerebral venous drainage, ensure adequate depth of anesthesia. All right, if you have neurological status monitoring intraoperatively, this is the time you will use it, your biceptal index score. All right, you want to make sure that your patient is adequately anesthetized. Analgesia, no pain, have opioid-based multimodal, all right, is important in this patient. Copious use of your opioid. Don't be afraid of respiratory depression as you're ventilating this patient. All right, make sure you have your drugs like mannitol, hypertonic saline, all right, especially in consultation with your neurosurgical team. Sometimes, all right, during their neurosurgical procedure, the brain swells up. They may do a craniotomy, all right, to give space for the brain to swell. And sometimes the surgeons may, have excessive brain swelling that require osmotic diuretic therapy intraoperatively. Like I tell people, you are the safety officer, right? Communicate with your surgeon as the case is going on. You can also see the brain expand. And you may also want to say, hey, guy, I think this brain is expanding excessively. You don't mind if I use mannitol hypertonic saline. So ensure that you keep your ICP under check. All right, there are different drugs. We've talked about mannitol, we've talked about hypertonic saline, 0.25 to 1 gram per kg bolus over 15 to 30 minutes for mannitol, and the hypertonic saline 3%, 2 to 5 ml per kg IV bolus usually used. For patients with raised ICP and metabolic acidosis, really we can use 8.4% hypertonic bicarbonate, right? A dose of 1 to 2 milli equivalent per kilogram IV bolus. Note that mannitol is a good osmotic diuretic, may induce hypovolemia with electrolyte derailment, so requires close fluid balance control. All right. Superiority of hypertonic saline has also been advanced because it gives you low volume osmotic diuretic effect. Okay, so monitoring is important. You want to do basic, advanced, and continuous neurological status assessment. All right, your biceptal index can be used, which is modified from your EEG, your somatosensory evoked potentials, your auditory evoked potential, especially all right during induction. All right, before you do your laryngoscopy and intubation, visual evoked potential, especially if you're doing pituitary tumors and all those tumors that cause the optic chiasma. So you want to do that. ICP monitoring is important here also. There are some centers that have ICP monitors. You can do continuous ICP monitoring to ensure your ICP is below 20 millimeters of mercury. So spinal cord injuries. All right, so this is a damage to the spinal cord which results in partial or complete loss of motor, sensory, autonomic function below the level of injury. All right, the cause is usually TIV, all right, trauma, tumors, infection, and vascular insults. All right, classification of spinal cord injury can be done based on mechanism, blunt trauma from hyperflexion, hyperextension, axial loading or rotational injury on the spinal cord. It can also result from penetrating trauma, stab wounds, or gunshot to the spinal cord. All right. It may also be classified based on neurological involvement into complete and incomplete. Incomplete spinal cord injury, we have no motor sensory function, all right, below the level of the lesion with easier classification of A. Incomplete, you can have some function preserved, which includes syndrome like central cord, anterior cord, and branchial syndrome. All right, it can also be classified based on the level of injury. All right, C1 to C7, which will give you tetraplegia with diaphragmatic involvement. T1 to T12 will give you paraplegia with loss of trunk control. Lumbar or sacral injury can give you paraplegia with preserved trunk stability. Okay, so spinal cord injury can occur from compression, all right, whether from vertebral fracture, from trauma, herniated disc can compress the spinal cord, or hematoma. Sometimes it can even result from your, epidural that you insert with bleeding, causing hematoma, causing compression of the spinal cord. It can be due to contusion or laceration where there's a direct trauma, all right, to the cord. It may also be due to complete or incomplete transection of the cord, all right, at the level of injury. So pathophysiology, like head injury, you can have primary and secondary spinal cord injury. All right, a primary spinal cord injury usually results from mechanical destruction of the neurons, axons, and blood vessels, which may manifest as either spinal shock, neurogenic shock, and it can even lead to impaired respiration mechanisms, especially in high cervical and high thoracic injuries. Know that spinal shock is immediate and is due to temporary loss of all neurological activity below the injury with flaccid paralysis and areflexia. Neurogenic shock is usually due to loss of sympathetic tone, especially resulting in hypotension, bradycardia, and hypothermia. Impaired respiration mechanisms release hypoventilation and hypoxia. Secondary spinal cord injury results from edema, which increases intramedullary pressure, further compromising spinal cord perfusion, all right, exacerbating neuronal injury. It can be due to ischemia, where there's impaired blood flow and hypoxia to the cord, leading to oxygen delivery, metabolic derailment, worsening urinary and glial cell death. Excitotoxicity and inflammatory cascade will all trigger oxidative stress, lipid peroxidation, and secondary demyelination of the cord. All right, remember the American Spinal Injury Association, all right, and we have the Asia, score of A, B, C, D, E. Know that A, all right, is complete spinal cord injury where there's no motor, sensory, or sacral sparing. Incomplete, we have no motor but some sensory sparing. Incomplete, C, 50% of muscles less than grade 3. All right, patient cannot raise arms or legs off the bed. D, incomplete, patient can't raise arms or legs off the bed. But A, E, Asia grade E, normal, there is normal motor sensory functions after spinal cord injury. So what are the key challenges for the anaesthetists in spinal cord injury? Number one, remember there's loss of sympathetic tone. Okay, so you can have both spinal or neurogenic shock, impaired respiration mechanisms. All right, this may lead to prolonged intubation and ventilation. And don't forget the risk of further cord injury from your secondary insult like edema or ischemia. So the goal of anesthetic management is to prevent secondary injuries to the spinal cord. Okay, airway management assumes spinal injury in all trauma patients until excluded. So the use of away fiber intubation is the gold standard, especially if there's severe instability or high spine injury suspected. In all of this, avoid neck flexion, extension, or rotation. All right, hemodynamic management, neurogenic shock, always look out for it. Patient with hypotension and bradycardia, all right, due to sympathetic loss, fluid resuscitation, all right, avoid overload, vessel pressures with norepinephrine or phenylephrine to restore vascular tone. Atropine is reserved for severe bradycardia. Always maintain your MAP between 85 to 90 in acute spinal cord injury in order to optimize spinal cord perfusion. Monitoring invasive A-line is important, all right? Core temperature measurement is important, and ensure that you have extreme care during transfer. A lot of times, incomplete spinal cord injury has been converted to complete injury due to patient movement. Ensure you are adequate padding to avoid pressure ulcers. Choice of anesthesia for this patient. All right, induction and maintenance agents should be chosen carefully. Within the first 48 hours of spinal cord injury, social maintenance may be used. But after this, to almost 6 weeks, some people say 6 months, you want to avoid SOSA due to the risk of hyperkalemia, all right, as a result of upregulated acetylcholine receptors, all right. Not the plasma muscle relaxant is prepared for longer procedures. Ensure you are adequate analgesia based on opioids and multimodal analgesic. All right. The impact of an spinal cord injury on respiration depends on the level of injury. All right. High cervical injury, C5 to C5, C3 to C5, compromises diaphragmatic action. All right, due to effect on the phrenic nerve. This would necessitate prolonged mechanical ventilation. Lower cervical, upper thoracic will also weaken intercostal and abdominal muscle function, and this will limit tidal volume generation and ability to cough. And this will predispose the patient to atelectasis, hypoventilation, and even pneumonia. So post-operatively, you want to anticipate prolonged ventilation, all right? Autonomic dysreflexia, risk in injuries above T6, you want to treat that, all right? Actually prevent and treat. Adequate analgesia, prevention of pressure sores, and tromboprophylaxis. So autonomic dysreflexia is a life-threatening condition which occurs in patients with spinal cord injury at or above T6. All right, these are triggered by bladder distension, bowel impaction, and bed sores, the 3 Bs. Okay, always remember 3 Bs. Okay, so during bladder catheterization, or patient with bowel impaction, which is common, or patient with pressure sores. So this is characterized by sudden hypertension due to the noxious stimuli, reflex bradycardia, headache, sweating, flushing above the lesion, and most importantly, often ignore is the nasal congestion that may come with it. So immediate action, number one, you need to recognize the early signs, all right, like we mentioned, sudden severe headache, sudden hypertension, sweating, flushing. So you want to sit the patient upright. This helps to lower the blood pressure by pulling, blood in the lower extremities. You want to loosen tight clothing and every restrictive devices, even to the point of losing your blood pressure curve. Okay, so number two, you want to identify and remove the triggering stimulus, check for bladder distension, okay, ensure you empty the bladder, all right, and make sure that the catheter is not kinked or blocked. You want to examine the bowels, ensure that there's no impaction, but be careful, all right, so that you don't worsen your autonomic dysreflexia. Look out for blood, bed sores, and other irritants like your ingrown toenails, fractures, tight shoes, and other invasive procedures. So if hypertension is not controlled with your initial line management and your systolic blood pressure is still greater than 150 millimeters of mercury, you want to use your fast-acting antihypertensive, your nifedipine sublingually, all right? Nitroglycerin may be used IV, hydralazine in severe cases. But more importantly is that you need to monitor your blood pressure every 2 to 3 minutes until it's stable. And we mentioned before, use subarachnoid blood procedures below the lesion, especially for chronic spinal cord injured patients. All right, make sure that you ensure standard ESA monitors, invasive monitoring. Okay, neuro monitoring is important. We mentioned that for head injury patients. Now, neuroprotective strategies, optimize cerebral spinal perfusion. Okay, keep your cerebral perfusion pressure always, okay, above 60 millimeters of mercury in head injury and MAP above 85 in acute spinal cord injury. ICP control is important with your head elevation. We mentioned this. Make sure you do not have too tight ETT ties or neck flesh. Osmotic diuretic may be used. Temperature management is important. You want to avoid hypothermia, which can worsen coagulopathy. And with your later child, like we mentioned, your coagulopathy, acidosis, and shock. You want to also avoid hyperthermia, which will increase metabolic demand. Know that hyperglycemia worsens neurological outcomes. You want to avoid that and avoid cerebral vasoconstriction or vasodilatation extremes by maintaining normocapnia in most cases. All right, anesthetic depth monitoring is important. All right, you want to avoid sudden changes in ICP during intubation, surgical stimulation, emergence. All right, make sure you always are in constant communication with your neurosurgeons. All right, use your biceptal index score for depth of anesthesia if it's available. All right, biceptal index system score is 40 to 60 is recommended. And this is important, especially right, for prolonged procedures. ICU management, I think we mentioned this before. Make sure you keep your head, okay? Avoid the H, end of bed elevation, okay? And note that end of bed elevation also helps to reduce the risk of ventilator-associated pneumonia, analgesia, most of the times opioid benzodiazepine combination, all right, is used in as much as it improves oxygenation, analgesia, and reduces anxiety. It also allows instrumentation, mechanical ventilation, and decreases oxygen consumption and carbon dioxide production. All right, anti-seizure therapy is usually very important, at least for the first 7 days. Okay, phenytoin. And one of the things we need to do, you need to measure the therapeutic level of your phenytoin, because most of the times we give phenytoin at sub-therapeutic dose, and the patient may not be prevented from having seizures. All right, your Keppral, your levetiracetam, all right, can also be used at least for a week. All right, make sure you always have your broad spectrum antibiotics prophylaxis ceftriaxone, all right, because it penetrates blood-brain barrier better. Okay, so for patients with head injuries, seizure prophylaxis is indicated for those who have school. School is a pneumonia, skull fractures, cortical contusion, hematoma, patient with open or penetrating head injury, patient with low loss of consciousness with GCS less than 10/15. All right, so management of intracranial hypertension is key. Okay, so what you want to do in ICP is to keep the ICP less than 20. Once you have ICP above 20, you want to treat, and we also use the mnemonic head. Hypothermia, therapeutic hypothermia lowers cerebral blood volume and cerebral blood flow, therefore ICP. Hyperventilation, all right, make sure you don't hyperventilate less than 30, all right. Elevation of the head to avoid venous congestion, all right. And adequate analgesia, diuretics, drugs, barbiturate coma may be induced in cases of severe intracranial hypertension. All right, this is where I use this all the time in all the ICUs I've worked. Always hug your patient twice a day, all right? And this applies to all the patients. Hug your patient. Fast talk infection prevention and control. You want to give adequate fluid assessment and management, and early feeding is important, all right? Early enteral nutrition, all right? Unless contraindicated, enteral nutrition may be started. Airway, all right? Extubation should be considered, all right, early extubation if neurological status are favorable. Okay, sometimes patients with severe head injury and severe spinal cord injury require prolonged ventilation, and you want to consider early tracheostomy. All right, monitor for the risk of airway edema, aspiration, secretion. Adequate analgesia is key. Sedation protocol. Observe the patient if they are alert, reckless, or agitated. And we use the RAS score in our center, which is important. I know that some people use the Ramsey sedation score, but here we use RAS score because it helps to graduate your sedation score for your patient. Most of the time, we keep our patient for the first 24 hours. I like to keep them flat, RAS between -3 and -4. And after after 48 hours, I keep them between RAS 0 to -1 to assess for GCS, neurological status, and readiness to win from ventilator. Okay, temperature measurement is important. Look at the core temperature always, okay? And the hemodynamics ahead of bed elevation. Urine output, watch out for diabetic insipidus and syndrome of inappropriate ADH secretion, especially for all head injury patients or patients with tumors, both of the brain. Pressure prophylaxis, pressure ulcer prophylaxis, and stress ulcer prophylaxis. Glycemic control is important. You want to maintain your blood sugar between 6 to 10 millimoles per liter. Avoid less than 6 because you can have the risk of hypoglycemia, which can worsen the renal injury. All right, general multidisciplinary teamwork is important. All right, so these are my references, and let's see if we can have some few times for contributions, questions, and additions. Thank you. I hope you heard me. I hope I didn't put you to sleep.